Hi, so this is another video on the theme of functional vision loss and ocular malingering. And again, I'm going to be taking you through an article. It's kind of quite similar in tone to the last one I did. So it's interesting to see that this is actually quite a standard viewpoint in the ophthalmology eye doctor field. This one is called Truth, Lies and Ophthalmology. It's by Valerie Pervin. It's in an online website called The Ophthalmologist. Functional vision loss, for anyone who doesn't know, it's when the problems you describe can't be measured. So someone might say, for instance, I can't see anything, looking at the autorefractor will prove that you can see things. So the patient could genuinely be saying it, and the problem could be neurological, the problem could be psychological, and that's a stance actually often taken by the eye doctors, the ophthalmology world when this happens. Or it could be the person is actually malingering and trying to cheat the system. But anyway, I'm going to go through all of this article, so it might be quite in depth, but I'm going to take it kind of line by line. So obviously, I was a bit shocked to read what was in it, so I've got my own bias. Someone else might have their bias, but here we go. So the heading is Truth, Lies and Ophthalmology, Tips for the Ophthalmologist Confronted with Functional Vision Loss. So there we are. And the first sentence is, well, the first step is to know the term, is to know the correct terminology. So the first thing she does is to say, well, there's subgroups within this term. So patients who have had a conversion reaction. So that conversion reaction is what used to be called hysterical or psychosomatic disorders. So basically that's another way of saying it's all in your head. Now, psychosomatic reactions are certainly a real thing, but it's like stress or depression is just very easy to make a lazy diagnosis of something that way. So there's the conversion reaction, and then there's those who may be malingering or pretending for whatever reasons. And she asks, but why don't we use these terms? Why don't we just say, why do we say non-organic? Why? So she answers the question. Well, basically it's to speak to the state of mind of the patient. And so already it's assumed that if something can't be measured and you can prove, well, there's nothing really wrong with your eyesight, then there's something wrong with your mind. Not even there might be something wrong with your brain, because it could be a neurological problem like a stroke. But no, it's something wrong with your mind. And she says straight away, you know, if you end up in court, basically, you know, I assume because of this, you know, some situation with a patient perhaps, you wouldn't want to find yourself being quizzed on your psychiatric credentials. So, you know, you don't want to tell someone it's all in their mind, because certainly in America, where you can sue people, you know, that could land you in court, basically, because an ophthalmologist would not be qualified to make an assessment on someone's, you know, mental status, well-being, whatever. So the saying non-organic vision loss, it's a way of keeping it within the field of ophthalmology, basically. So covering your back. She does allow that it may not be a black and white issue, and there may be some genuine impairment, but the patient's exaggerated their symptoms to make sure the doctor doesn't miss it. So she's allowing, you know, that concern there. So her first advice is to look for indifference or hostility, and she uses the term label indifference. So with conversion reaction patients, she says they sometimes exhibit label indifference, and that is an inappropriate response, almost an indifference. Okay, so their problem, because they're not deliberately trying to deceive the system, so they tend to be pleasant and cooperative. Okay, so if you go into an optician with a problem which they can't immediately measure or assess, and you're nice and polite, that's a problem. They are also notoriously suggestible, and that's how they've become convinced of their illness to begin with. Right, so if your symptoms can't easily be assessed or diagnosed, then you're a suggestible person. Yep. Okay. So she goes on to say that, right, so in contrast to the conversion reaction patients, who can be all ages, malingerers tend to be young adults. So I don't know where the research is, you know, to support that. So they're likely to be under pressure at work or with finances, and have trivial trauma history, and they're frequently hostile to the examiner. So, okay, if you go in and you're grumpy, then that's a problem. I'm not saying you should go into the optician and be grumpy, but it could be that people have been to lots of or other opticians before without any help, and they're a bit cynical about it. So patients who arrive late or ones that have to leave early, the ones who take issue with the methods, and this is interesting, as you're just doing the same, or they make comments, you're just doing the same test as the other doctor, or you're not going to use those lights, are you? The other doctor did that, and I had a headache for days. Now, okay, ding, ding, ding. This is where the red flags really go up. There were little red flags before, but here they really go up. So the patient that is upset that the same test is being performed again is probably the patient who had the test, that test before. They couldn't find a problem, but the problem still persisted for the patient, so they're going back in, hoping for a different test, to see if they can get to the bottom of the problem. So, even if that was under the conversion disorder, that's still not okay. But as that being indicative of a malingerer, I find a bit problematic when that is, a problem for a lot of people who go to the doctor or the, optician or whatever with an ongoing problem, and, they can't get it fixed. And they're usually told it is all in their head or something. So that does no service to the patient at all. And the second comment, you're not going to use those lights, are you? The other doctor did that and I had a headache for 3 days. To me, that actually sounds incompetent on the part of whoever's testing. And I guess I've got a personal interest in this. I find some tests, they are painful to take. I don't really like anything coming too close to my face. I don't like strong lights being shone in my eyes. One eye is tolerant, the other really isn't. And yes, I do get headaches for 3 days. So the idea that someone thinks that that is malingering, and also there are certain subgroups of people who are going to have problems with strong lights. So anyone on the Asperger's or ADHD spectrum, and a lot of people haven't had a diagnosis, haven't sought a diagnosis. They just know that they got certain types of problems or problems with flickering lights, or what have you. So those patients are going to have a problem with lights. They may not also be able to communicate that well with, you know, their optician or their doctor. So, you know, an ophthalmologist or eye doctor with this attitude is going to be really, really bad for that type of patient. So this lady is advising that other, you know, eye doctors take this stance with, you know, functional vision loss or malingerers, and treat them as such based on the fact that they may make statements like that. I do find that particularly bad, I have to say. So back to the malingerer, the recent trivial trauma. So this is very judgmental. What is a trivial trauma to her might not be to that person. So she says it's often job related. You know, commonly perhaps someone's splashed their eye with something and it was treated, and I'm going to quote what she says. The eye was irrigated and patched, but when the patch came off 2 days later, bam, it was blind and has remained blind ever since. So she's dramatising that person's experience. So, you know, for the malingerer, they're being over dramatic. That's assuming they are actually malingering. So the next paragraph headline, paragraph heading, control your frustration but also listen to it. So okay, you're going to get frustrated with your clients if they make certain statements. Yep, that is really good customer service. Say no more. So the patients, and I'm going to quote, who arrive in our office already displaying aggressive or hostile behaviour can be upsetting for us as physicians. Okay, so this is all about you, is it? I thought it was supposed to be about the client and helping that client in the best way you can. But it's also a very helpful diagnostic clue. Maybe. It can be an indication to at least suspect that a patient has a hidden agenda. Okay, so the first thing you do is to suspect your patient. So far, this article is about basically making snap judgments about your patient, suspecting them, you know, suspecting them of not being honest. Yeah. Someone could be aggressive or hostile because they could have had a bad experience before. I mean, it may be something completely unrelated. They could be on medication, they could have some, you know, illness, or they could have even had a bad day. That's not excusable. But there could be many reasons why someone could be hostile or aggressive. It could be a clue. But the way to find out about it is you ask the patient. Well, obviously you're not going to ask them, why are you aggressive and hostile? That's going to get their back up. But some clever questions can, you know, root out, or maybe they've had a bad experience before, maybe, you know, they're frustrated with their own problem. So yeah, better, maybe some better people skills are needed, you know, like communication. Okay, so most of your patients are visiting you because they want to get better. So, yeah. So the person who might be overly cooperative or hostile, doesn't want to get better. The person who's aggressive or hostile could be really frustrated and at the end of their tether with the problems they're having. Okay. But anger from the patient isn't the only clue. Oh, I love this one. If you actually feel yourself becoming upset or frustrated, apparently that's another clue. So, you know, your feelings within yourself, you know, your own emotions. Okay, this is now a tool for diagnosing a patient. Follows on with some quite sensible advice. You know, don't fall prey to this, and I'm going to quote again, by reacting with a comment, well, do those other doctors know what you had? I guess not, because that's why I'm examining you. Yeah, this is the first sensible thing I've seen in this article so far. Okay, yeah. We get on to something else. Another clue is sunglasses. And if the patient comes in wearing dark glasses, and it's noted sometimes more than one pair, and a hat with a brim, you know, and having their collars up, and you have to, you know, take each thing off to examine them, and in, you know, so doing they appear to be in agony. Oh my God, no, don't do that. And she says it's almost like unmasking a vampire. Oh dear, I have a real problem with that. If they're telling you they're in pain, instead of taking it with a big pinch of salt, you know, you should take them at their word, because they may well be. And it's not your business to decide whether they are or are not, or even whether their pain is that bad or it isn't. I mean, it's different for every individual. And for some patients and for some groups of people, light is going to be a problem. I've been there with the dark glasses and the hat with the brim, and you know, having the eye doctor kind of treat it as trivial wasn't pleasant. Yeah, it did leave me with headaches for 3 days at a time. You know, I don't have that problem now, but it's not because I've decided to stop malingering, or, you know, I've got over my trauma. It's because I did have an actual problem. I did need glasses, I got the glasses, and now I have much less of those problems and I'm better. But also it's not just the fact that if you, you know, with someone on the autism spectrum, you know, their eyes are going to hurt if you take off the dark glasses. It's also that they don't like being touched often, so that's something they're going to find scary. And physical touch can be quite disturbing, and also the whole boundaries thing. So I'm not saying this lady is, you know, wading in and grabbing things, but you need to find out where that person is coming from. And just because someone isn't diagnosed as Asperger's or autistic doesn't mean they might not have that condition and those problems. And also in an indoor environment, light sensitivity to electric lighting can be a real problem because of the flicker, and I've kind of been there as well, and I used to wear dark glasses because the lights were flickering and it actually used to hurt. I don't have that problem now, but yeah, I mean, it certainly is a real thing, and you know, the lady seems to be making light of it and, you know, sending this advice out to all the other eye doctors. I think that is really, really bad. So she then goes on to say, right, there's a number of tests you can do, and to suggest using the power of suggestion. So you can't find an answer for this patient, so what do you do? Well, you already know that patients with conversion reaction are suggestible. Ah yes, so if you can't find you know, a diagnosis for them, they've got conversion reaction or malingering, that says something about the way they think, and in that case they would be suggestible to the idea that their condition is improving. So malingering patients, you know, they might say that they can't see, but they often don't know the right answer to give to your questions. So they look for any clues that will help them to convince you that, you know, their problem is real. So, right, I don't quite know where she's going with this. She's going to double the size of the letter, tell them it's twice as large, and they might respond saying, oh yes, I can see it now, and then telling them, oh, this pair of glasses should clear the problem up, and they agree to it. Yeah, I'm confused. I don't know where she's going with that. I think if she's saying, you know, doing nothing with the letter and telling them it's twice as large. So I think she does need to be clearer about what procedure she's describing there. She's saying she's not comfortable with a dishonest approach. So she says this is what she does. So you explain in a non-judgmental way, because yes, she is so non-judgmental, that you believe the problem is not physiological. So you would say things like your vision is better than you think it is, your eyes are playing tricks on you, your brain is capable of seeing better, your brain isn't letting in the good vision, and then in quotes she says, should you end up on the witness stand, you don't want to find yourself being quizzed on your psychiatric credentials. So I don't know if she put that in by accident, because that was, I quoted that at the very beginning. So whether this was meant for the patient or whether it slipped in by accident, I really don't know. But this kind of says nothing, and in some cases the wrong thing. So your brain is capable of seeing better. Well, that assumes knowledge of the brain. So that assumes knowledge that is beyond the remit of an eye doctor. That assumes neurology knowledge, or your brain isn't letting in the good vision. Really? I could see that being taken to court, certainly in the USA, but I guess this is something that would just be said and not written down. Maybe she would do that. So next you give an explanation, and I'm going to quote this little bit, and it's a guideline of the sort of things you would explain. Obviously your vision was very poor when this started. You were legally blind in that eye after what happened, the splash, the hit on the head. How scary that must have been for you. If I were you, I would have been thinking, oh my gosh, what if it doesn't get better? What if I can't work and support my family? What if it just never goes away? Your thoughts were so scary that your brain went into a spasm. Meanwhile, your vision has improved and the problem has gone away, but now your brain is not letting the vision in. Okay. Right. For anyone having ongoing problems with eye assessments, you should really get the eye doctor to write down what they say, because there are a lot of problems with this. Obviously your vision was very poor when this started. Well, was it measured as very poor? What credentials does she have to make that judgment about your previous vision? And if she doesn't have those figures, I think legally she's got no business saying that. You were legally blind in that eye after what happened. Again, if there was no actual record of that, would that be, legally permissible to say that if you couldn't verify it was actually true? How scary that must have been for you. If I were thinking of you, if I were you, I would have been thinking. So the intention I can see with that is to kind of, come to the patient's level, to, try and show empathy. But this is also making a value judgment about what the patient is thinking, and how their mind is working. Those thoughts were so scary. Your brain went into a spasm. Your brain, that's neurology. Was that measured? Was that assessed? Was that diagnosed? If not, does she have any legal basis for making that statement? Meanwhile, your vision has improved. Again, was it measured? And the problem has gone away. And again, but now your brain is not letting the vision in. Can that be assessed and quantified? If not, is should she be making that statement? And could that be tried in court? Now I don't know about the court system in the USA, but in the UK it couldn't, because you can't, because the Optician's Code of Practice, which I've definitely done a video about this. Right, my residents, so this lady teaches other opticians or other eye specialists the brain spasm speech. So you trot it out to patients who basically you don't believe. So then you go on to the prediction. So you tell them that their vision will improve, and you tell them maybe, it'll get better every day from the outside to the centre. That just sounds, that sounds like dodgy science and dodgy medicine to me. This lady is not a psychoanalyst. As far as I know, she's not a psychiatrist. She's not a psychologist. I don't think she really shouldn't be going there. You'll see some improvement tomorrow, more on Friday. By Sunday you'll be almost better, and on Monday morning your vision will be back to normal, which means you can return to normal life. So that's more, you can go back to work. Yeah, well, I can see that this would this is so vague that it wouldn't hold up in court. So maybe, given she's going to take the approach she is, maybe that is the most sensible thing. Obviously not for the patient, but for her to say to the patient to cover her back. And she then hands them a note clearing them to go back to work, which she's prepared before she's even entered the consulting room. So, she's got this value judgment before she's even seen the patient. So basically, the diagnosis has been made before the patients come in, so she's pretty much wasted their time. And also, because she's not looking for any condition, something could you know, something could be missed because of that, and it could actually be something serious. She won't recommend further testing because she's done all the tests. She won't suggest a return visit because she doesn't want to give them the wrong message. So she wants them to go away with the idea that everything's fine. So this is specifically for malingerers. But this person could end up having to go back to work, you know, maybe working at a computer. They've still got the pain. You know, what do they do then? This puts someone, you know, really between a rock and a hard place. And it's deliberately intended to be coercive. And she also says normally she would give a patient time and space to ask questions, but if she's decided, you know, when I'm managing a malingerer, so she's already decided at that stage that they're putting it on, basically. And she says, I don't want to know what the patient thinks about it. Right, so because the patient could then come back with something which is useful information. Now they may well be trying it on. You know, I'm not saying that you know, people don't try malingering with eyesight. They clearly do, as much as, you know, any other condition like bad back or bad leg. But I think with her method, this is not only going to catch people who actually are malingering, but it's going to catch an awful lot of people for whom this really wasn't intended, and it could put them between a rock and a hard place. She goes on to conversion disorder. So you suggest that the patient is okay, that they're already getting better. The problem is you've got a pre-diagnosis, you know, in your head. You've decided for that patient. You're not listening to anything they have to say. And what they say could be giving you important feedback. It could be giving you really important information. That's the problem I have with that. So, and she ends up saying, oh, if you don't feel comfortable considering sending the patient to a neuro-ophthalmologist, well, you know, if you're making such statements as your brain isn't letting the good vision in, then, you know, if you feel confident enough to make a statement like that to a patient, you should actually be sending them to a neuro-ophthalmologist. Else you've got no business saying that to anybody. She says, well, we may also find some of these patients challenging. Well, I expect you are if you've got that attitude. But they're definitely within the scope of our field. Well, yes, because they pay to come to the optician, especially in America. I mean, you know, it either comes off the insurance or out of the pocket, so there we are. We're always happy to help. I love that closing statement. Always happy to help in a very unhelpful way. So yeah, that was the article. It took a little bit of time going through it, but yeah, and I guess to wrap it up, I think this is very much standard for the you know, the eye care, the eye professional field, and that's a bit of a shame, because you know, it does mean that you know, as with any condition, some of them are going to be a bit harder to get to the bottom of, and you know, they need care and attention. Maybe the patient will have to come back over months, over years maybe, to see if they can get their condition managed. So it's a real shame that you know, opticians and eye doctors are taught to take this approach, because it, you know, it cuts off a lot of people, you know, straight at the pass, and it means they live with problems that, you know, they don't have to. And I think a lot of it could also be like, you know, simple interventions that could help a lot, and you know, and in some cases then you're going to miss out more serious things, so patients suffer unnecessarily, you know. And also, you know, then there's the question of you know, you rack up complications, and you end up with a serious eye condition that could have been treated early on. So yeah, hope you found that helpful, and yeah, look forward to my next video.